Welcome to our final session of the program. The theme is Beyond Ablation, integrating smart monitoring, mapping, and neuromodulation. Our final presenter is Dr. Vivek Reddy, is currently on a flight, so has kindly recorded his presentation, which we will view in a moment. But first, let's welcome our panelists. I have the great honor of welcoming Juan Zerpa Acosta from Sao Paulo in Brazil, Dr. Shephal Doshi from Santa Monica, and Dr. Rahul Doshi from Scottsdale. So without delay, let's take a look at Vivek's presentation.
I'm delighted to be able to present this talk on Beyond Ablation. These are my disclosures, and I will be discussing some investigational devices that do not have regulatory approval. By way of introduction, let's talk about what I consider the real danger of pulse field ablation, and that really is the issue of overablation. When you think about anatomical targets, and there are many, PVI, posterior wall, extensive posterior wall, different linear lesions, even the left atrial appendage. So the issue is that every lesion set probably will add some increment in success. The problem of pulse field ablation is it decouples safety and efficiency from the procedure. So it's very easy to overablate and suddenly end up with a situation like this where you've ablated the whole atrium. And it's compounded by the fact that our trials are basically based on acute safety and chronic effectiveness without a concern of the impact on LA function. And that may start to change, and hopefully it will change, but it's something that we have to deal with. So I think the question is, how do we get away from overablation of the atrium and still achieve success? So I want to cover a couple of things. First is mapping, and there's a number of different publications that have covered different mapping strategies. I want to cover 4 of them. The first is spatiotemporal dispersion. The concept here is highlighted here on the left. If you have a multi-electrode catheter, and let's say it's staying where it's positioned where there's a rotational activity, for example, then you can imagine that the aggregate of the electrodes, you'd actually see all these electrograms here. As opposed to in B, where you have a passive sort of location, then you just have a wavefront sort of sweeping past this, a putative, not interesting area. So there was software that was developed basically to homogenize the technique of doing this procedure. And this is the trial called Tailored AF. So this is a trial looking in persistent and long-standing persistent AF patients. And what was seen is compared to a pure PVI approach, when you add tailored ablation, it improved the success of freedom from atrial fibrillation. This is a single procedure off drugs, as well as in the protocol population. Pretty impressive difference between these two cohorts. Now, that was freedom from AF. What about freedom from AFib, flutter, tachycardia, etc.? Well, it was similar, but didn't quite reach statistical significance. With multiple procedures, yes, it did have a p-value less than 0.05. Now, if you look at about half the population who had, let's say, AFib lasting a little bit longer, that is more than 6 months, then regardless of how you look at the data, freedom from AFib, fib flutter, etc., as single, multiple procedures, there was statistical significance. Now, obviously, this is a secondary unpowered analysis. But still, this is, I think, what makes this technology interesting. What are the limitations? Well, part of it may be this. Of course, there's additional mapping time that's required. And also, when you look at the total amount of additional ablation, what you see is a fair amount of additional areas that are targeted. Now, the technology is evolving. They have what they call prioritized dispersion sites based on different aspects of what they expect for AF sources. There's no randomized data here, but there is a non-randomized pilot, which is interesting. If you look at this, these white dots represent the dispersion points, and these yellow dots represent the prioritized dispersion points. Notice that it's a subset of the full dispersion points. And what you see is when you compare in this 25-patient cohort compared to the tailored study, you can see that the procedure time is a little bit faster, mapping time is faster, total RF time is better, and yet the metrics in terms of acute metrics of acute sinus rhythm by ablation or AF termination were similar, if not slightly better. And if you look at the outcome, the 1-year outcome, there was no difference between these groups. So this suggests that these prioritized dispersion, this prioritized dispersion strategy may hone the sites and improve the specificity without a significant decrease in success. And of course, prospective trials are required. Let's go on to the next approach, which is so-called electrographic flow. The concept of electrographic flow is as follows. You take a 64-pole basket catheter, collect unipole electrograms, run through these various algorithms, and ultimately you end up with the statistical hotspots. What exactly is happening? Well, what this technology is looking for is flow of activation away from a location. So, for example, in this location here, with this arrow, activation is moving away from this location. So whatever is the mechanism, it suggests that that area is driving the rest of the atrium. On the other hand, for example, if you look at this location, yes, there's rotational activity here, but flow is heading toward that location, suggesting it's just a passive rotational activity and not really critical to the tachycardia. This was studied in a randomized pilot study. It's a complicated study, but basically patients that are coming back for redo ablation, they came back and 80 patients underwent mapping. Now, in some of the patients, there were no sources found. But in those patients where there was a source found, what happened was after PVI, the procedure was either stopped or they underwent treatment of those sources. And here's what was seen. If you did re-PVI alone, the success was really dismal. It was almost 100% failure. But when you add EGF-guided ablation, the success was substantially better, with a hazard ratio of 2.7 and a p-value that was significant. Now that's freedom from atrial fibrillation. What about freedom from all atrial arrhythmias? There, again, substantial difference, but this does not reach statistical significance. Again, this is a pilot study, and larger studies are needed. The other really interesting aspect of this technology, and probably the most interesting aspect, is this. The mean number of sources per patient was only 1.3. So the specificity of this technology appears to be reasonably high if it works. So there's large prospective randomized trials that are commencing, and I think will really inform our understanding of this technology. Also, ultra-high density mapping. So what is ultra-high density? Well, this is a grid-like catheter that uses these high-resolution microscale electrodes, and it is magnetically tracked. Now, what's interesting is they use a closed unipolar configuration, so the electrodes are stacked on top of each other. So each electrode is sort of omnidirectional in the sense that because its bipole is sitting on top of it. Here's an example in a ovine persistent AFib model from Bordeaux. On the top, you see this ultra-high definition array. On the bottom, a traditional grid catheter. And notice that when you use very high resolution, what looks like otherwise really complex fractionated electrograms get resolved into very discrete electrograms. And so it's unambiguous, the local activation timing. So here's an example using in a patient. This is in a first-in-human study. Here on the left, you see activation heading sort of inferiorly, and then on the right, you see activation heading superiorly. So this is in the same patient. There's these two sources. This is before, by the way, any ablation. What was interesting about this patient is after we just ablated these two sources, the AFib terminated and it was non-inducible again. Now, of course, per the protocol, we also did PV isolation, but this is an interesting example. And so prospective randomized trials are ongoing to look at the effect of this technology. Also, let's look at digital twin-based ablation. So this is another concept I think is very interesting. And there's some recent randomized data. This is work by Dae-Hoon Kim and Hyun Pak. And what they do in their technology, the so-called CUVIA technology, is take a pre-acquired CT image, intra-procedure electron anatomical mapping, and then based on certain assumptions about fiber orientation, etc., they run it through a simulation. So basically, they do an electronic EP study, and this is all simulated, and they are able to identify certain areas where rotational activity, an AF source, might actually sort of become stable. And then that's sent over to the EP lab, and then the operator can target that for ablation. So this CUVIA technology was recently studied in a multi-center randomized trial. A total of 304 patients with persistent atrial fibrillation who are undergoing first-time ablation were randomized by trial center to either empiric PV isolation or PV isolation plus this digital twin guided ablation. This study was conducted in 4 centers in South Korea, and the primary endpoint was any documented atrial arrhythmia exceeding 30 seconds after a 3-month blanking period with or without the use of antiarrhythmic drugs. That was the primary endpoint. And here's the data. So first of all, what you notice is in about half the patients, there was a stable source that was identified, which also means in half, there was no additional ablation performed. It's also interesting that there were a mean number of 2 sites identified per patient. So again, a high specificity. And what was seen was pretty impressive results. You can see that when digital twin-guided ablation is added here in the orange line, the success rate improves substantially with a hazard ratio of 0.52 and a highly significant p-value. Now that's freedom from arrhythmias off or on antiarrhythmic drugs. What about the success off antiarrhythmic drugs? Well, here's the data. Again, there's a significant absolute difference and a statistically significant difference, though the magnitude effect is a little bit less than on or off antiarrhythmic drugs. Now, this is, again, a reasonable size prospective randomized trial. I think this does need to be studied again in a larger trial that includes more centers. Now, let's talk about other adjunctive strategies, including metabolic strategies. There are a number of studies indicating that abstaining from alcohol reduces the burden of AFib. Interestingly, in individuals that drink caffeinated products, if they abstain from drinking caffeine, actually not only did it not help, it actually seemed to worsen the amount of atrial fibrillation. And of course, risk factor modification. There's been a lot of work on this. Let me show you one of the most recent studies called the ARREST-AF randomized trial. This is a randomized trial that was just published where patients who had persistent AFib, about 60%, the rest paroxysmal, and a BMI that was elevated at a mean of 33, were randomized, and importantly, all patients had implantable cardiac monitors, but they were randomized to either usual care, that is standard ablation, versus standard ablation plus this risk factor modification. What was seen was a significant improvement, of almost a 50% improvement in success. Here you also see that there was an improvement in BMI as well as an improvement in weight in the risk factor modification group. The question, of course, is can you scale beyond Australia? And because a number of other centers have tried to reproduce some of these data and been unsuccessful. Probably the answer is going to be here, using some of the newer agents like the GLP agonists that may help with reducing weight. And finally, I want to talk about autonomic modulation. And there's 2 specific strategies I want to discuss. First is an interventional strategy, which is the concept of renal denervation. There was a large trial called ERADICATE-AF that was published about 5 years ago that took about 300 patients who had both AFib and uncontrolled hypertension with an elevated blood pressure as shown here. And they were randomized to either cryoballoon ablation or cryo plus renal denervation. And denervation was performed with a conventional RF ablation catheter. Here's what was seen. You can see that compared to the control group of PVI alone, adding denervation improved success substantially with 43% less recurrence. So this did improve outcomes. Now that's in people who had uncontrolled hypertension. Now again, that was uncontrolled hypertension. What about controlled hypertension, which represents the majority of our patients? Well, we did a study called the Ultra HFib Pilot, where we took patients who had atrial fibrillation undergoing a first-time procedure, and we again studied denervation. This time we used an ultrasound denervation catheter. As shown here, it emits a circumferential ring of ultrasound energy to ablate around the renal arteries. So ultimately, 107 patients were randomized. Notice that the baseline blood pressure was controlled, and they were randomized to either ablation alone or ablation plus renal denervation. And here's what was seen. As you can see here, the success rate with denervation in red improved success beyond just AF ablation alone. Now, this did not reach the study, but it was a very interesting data. And of course, this needs to be followed by bigger studies. And how important is this? What is the potential clinical impact of adjunctive denervation? Well, let me just show you a couple of studies. These are recent databases, including tens of even hundreds of thousands of patients. And what you notice is the percent of patients that have hypertension is substantial. On the low side is 58%. On the high side, it's 87%, partly as a function of age. So the point is that if successful, denervation could have a tremendous impact in our AF population. Finally, I also want to talk about cutaneous neuromodulation. Most of the data is here with this tragus nerve stimulation that the Oklahoma group has published extensively on. This was their TREAT AF randomized trial. It was a single-center trial, very interesting trial. This has nothing to do with ablation. This is just looking simply at paroxysmal AF patients. And if you follow the amount of AFib over time, not surprisingly, it increases over time. But if you do tragus stimulation, not only does it not increase, it actually decreases. And this was a statistically significant result. Now, beyond tragus nerve stimulation, there's another cutaneous target, which is the median nerve. So the concept is to use this wristband-like device that has these stimulating electrodes to stimulate the median nerve. And this has a very similar physiology to tragus stimulation, where there's a central effect affecting the nucleus tractus solitaris and causes this low-level vagal output that has favorable effects on the heart and inflammatory markers. And there's a study that's actually looked at this called the BEAT AF. This is a pilot study. It's a sham-controlled, double-blind pilot looking at patients who had paroxysmal atrial fibrillation. And they're randomized 1-to-1 to either median nerve stimulation or sham stimulation. And these are 20-minute sessions 3 times a week for symptoms. It was a 2-center study conducted in Tel Aviv. And the data basically is as follows. There was a significant reduction in PAC burden, as well as an improvement in ERA class based on the reduction in the PACs, as well as a non-significant reduction in AFib. Again, this is a small study of only 31 patients, but very interesting. There's another study called the Neuropulse study, which is ongoing, also a sham-controlled, double-blind randomized trial. And this is looking at patients who are planned for ablation, either a first-time or redo ablation for paroxysmal persistent AFib. After ablation, they're randomized 1-to-1 to either median nerve stimulation or a sham procedure with a number of different markers over a 6-month period. The primary endpoint here is looking at AF burden. This is being conducted at a total of 3 sites. The study is ongoing and should yield some interesting results. But the hope is by using these various strategies, whether it's more targeted ablation or using other adjunctive strategies, invasive or non-invasive, this may improve our success of ablation without additional atrial destruction. Thank you very much.
Well, I have to thank Vivek for that incredible presentation. And now we actually get to talk about his talk without him being here behind his back, even better. So, Juan, you're the nicest of all 4 of us here. So I'm going to start with you. When in this world where ablation and mapping and all these technologies that Vivek showed and neuromodulation coexist, what will be the new endpoint be? Is it going to be electrical silence or autonomic stability, substrate transformation, or continuous rhythm surveillance? What is your prediction?
Something that we have learned is that only PV isolation is not enough. We get better with this, we get better isolation of the veins, but the results needs to improve a little bit. All this led us to the analysis of the electrograms and what happens when you ablate these fractionated electrograms. Maybe with these high definition tools, we are getting into this another level of scale, understanding the atria as we understand the ventricle. And these tailored solutions and these redo procedures just help us to improve these kind of procedures. Also, in autonomic denervation, we know that sympathetic have a lot of work to do in AFib induction, but also parasympathetic tone has as well. As Sonny Po and the Oklahoma group has presented, the vagus stimulation has this effect over diminishing the inflammation and also the AF burden. What we don't know if we could do the PV ablation with radiofrequency, we also have this denervation effect, and this may help to this. This may be going through analysis to randomized trials as well.
Rahul, let me ask you a question about combining some of these strategies. So, There is definitely a rise in AI-driven monitoring, and we are seeing more and more high-density mapping solutions. Are we finally maybe approaching a point where we can predict arrhythmia behavior rather than just simply reacting to it?
That's of course the $1 million question, right? And those of us that are old enough to have seen one iteration or another regarding trying to refine our targets or trying to tailor our approach, some of these have broken down with whether it's more data or whether it's just continued or longer term follow up. And I think that that's still the way I mean, on one hand, I'm so excited that, these technologies are out there and that they're continued investigation. On the other hand, I think we do need a cautionary note. I do think that whether it's, you could look at it in a variety of ways. You could look at what we've seen with tailored approaches. Well, those tailored approaches that target point zero, you know, are we modifying that target? Are we modifying that substrate when we target those approaches? That has been suggested with previous technologies. It does seem like some of these things, like Shephal has talked about, some of the flow mapping things, that maybe it holds up, or maybe it's a little bit more persistent in that target basically being eliminated, and you're not shifting or moving the goalpost. Autonomics, I mean, let's face it, are we smart enough to outsmart the autonomic nervous system? I mean, renal denervation still isn't here for hypertension. And now we're talking about it for adjunctive therapies for atrial fibrillation, right? And as time goes on, does the autonomic nervous system just outsmart us once again? But I would, my optimistic approach to this or viewpoint on this is that I'm just glad that we still continue to look, right? And we know we need to do better. We know we want to move beyond plain and simple anatomic approaches. Whether it's adjunctive ablation or adjunctive therapies, this is exciting.
Yeah. Shephal, let me ask you a question about heart failure. We had a long discussion about heart failure and AF management today. How do you see these smart monitoring transforming rhythm management in heart failure? I mean, we know autonomic tone and arrhythmias are so tightly linked. Vivek talked about a lot of new technologies. How is it going to change heart failure management for these AF patients?
Well, I mean, the proof is in the pudding in terms of the data. I think we are so desperate, as Rahul was saying, of wanting to have these technologies work for a multitude of different disease states that, again, there are small studies and we need to kind of validate these. And at the end of the day, I mean, you look right now, even whether it's in heart failure or standard AF, right now in the US, overall, the patients getting ablation, paroxysmal patients, over 50% get their posterior wall done because it's easy. Persistent patients, it's 85%. So combining two, it's 70%. And in heart failure patients, there's even more ablation being done for that same reason. And so at the end of the day, I think we are so desperate for technologies to help us define this, and we want to get excited before we have more than 50 patients of data. So I think we just really need to, because we've been burned before, and I think we need to learn this better. And I can tell you in our community in the West Coast, everybody wants a non-invasive strategy. You can call us hippies, you can call us what we want, but there's a lot of excitement because we want this autonomic stuff to work. You wear something on your ear, you wear a wristband, and suddenly arrhythmia is gone. So, as we see in the field where there's a demand, there will be research, and hopefully there'll be innovation. And I think that's the only thing I can hope for.
Juan, let me ask you a question on how this comes into the global practice. So, how do developing regions adopt things like smart monitoring and neuromodulation for that matter in a more scalable way without us widening this global EP practice gap that we see?
We managed to follow the US and the Europe approach because we are kind of behind here with the availability of these technologies, but also trying to get this into the clinical practice just to help us to monitor these patients and trying to find this arrhythmia. Maybe sometimes you have these patients without any symptoms and you need more tools to try to find how they are developing after the ablation. As well, if you don't look for it, you're not gonna find it.
So one final question, and I'll let both the Doshis take a stab at it. Do you think continuous smart monitoring eventually will kind of become the command center that's going to decide whether a patient needs mapping, ablation, or neuromodulation or what type of mapping for that matter, and essentially making it automatic, like, or automated for that matter, rather than a physician actually trying to put their head in, because we obviously have not done a great job in figuring out which patient needs what. Um, do you think this is going to be the future, or no? I'll start with Rahul.
Should the younger, more handsome Doshi go first? I think I'll just go
Sure.
ahead and start. Yeah, I mean, I think like times have changed a lot, especially the way these smart monitors have evolved. Ultimately, I see the scalability and the availability of these. I think this is the future. I think when we had to do an implant, a large implant, it was a different story. But we have been fooled by technologies thinking they're working based on symptoms, based on 1 week monitor here and there. And I think the only way to really assess all of these different novel concepts and techniques is to have most scalable smart monitors to know if we're having any efficacy.
So I will, as the older and less handsome Doshi, I will add to that in saying that, yeah, this is a numbers game, right? So this is going to be driven by big data, right? The Apple Heart Study, right? In a matter of months, 500,000 patients, right? It's incredible the power of this, and we've learned with machine learning that how powerful even a simple snapshot like an EKG can do things like predict your risk of left ventricular dysfunction, atrial fibrillation, sudden cardiac death, et cetera, right? So I agree with Shephal completely that smart monitoring will rule the day and drive our interventions. And I think the uptick is actually going to be further driven by some of these therapies, whether or not they have some role or not, right? So you combine a smart monitor with some sort of therapeutic intervention like cutaneous nerve stimulation or whatnot. And now you've got something that is, and it'll probably be marketed direct to consumer. There you go, right? It will take over whether we want it there or not, right? So,
Well, on that note, I am going to bring this session to an end. So that truly brings us to the end of this final session. Huge thanks to Vivek for recording it. Hopefully he didn't do it on his flight. And thank you, Juan and Rahul and Shephal, for a great discussion. Join me now for our meeting summary.